Welcome, ladies and gentlemen, to the 6th UK Histio Forum. The forum is hosted annually by Histiocytosis UK. Before we introduce our distinguished host and speakers today, there are a few points of housekeeping and participation. The webinar you are about to view or participate in is for information purposes only. It is not medical consultation. Patients, parents and carers must speak with their personal medical team regarding their specific circumstances. The speakers today will not take personal medical questions. We will be hosting a Q&A session following each speaker's presentation. We may not be able to answer all questions due to time constraints. We will, wherever possible, follow up with any additional information that becomes available. The webinar is being recorded and will appear on histiocytosisuk.org. Participants will be muted. At the end of the session, there will be a survey. It is anonymous and we would welcome your feedback. Those of you attending the LCH session will be given instructions on action to take after Dr. Booth's closing summary. How to ask a question. You can submit questions using the Q&A feature in your webinar panel. Before typing your question, please check to see if someone else has already asked the same or similar question. If they have, click the like button, that's the thumbs up button. This will promote your question and show the speaker the most popular questions first. If you are unable to see the Q&A window, click the option on your toolbar to open the window on your screen. Type your question and submit. Please note we're not using the chat or any other method today to submit your question. I'd now like to hand over to Dr. Claire Booth to introduce her guests.
Hi. Well, thank you all very much for joining us today. My name is Claire Booth. I'm a paediatric immunologist and gene therapist at Great Ormond Street Hospital with an interest in HLH, primary HLH. And today we've got a fantastic lineup of speakers covering both paediatric and adult topics, with a slant on the highly relevant COVID as well. And so we're going to go through the speakers' talks, and then after each talk, you'll have the opportunity to ask questions. So I'm delighted to introduce these are our speakers. Dr. Alistair Bamford, who is a pediatric lead for pediatric infectious diseases at Great Ormond Street Hospital, who has had a significant input in the COVID pediatric population. Anu Rao, who is a pediatric hematologist at Great Ormond Street Hospital, who has a long-standing interest in primary HLH and its novel treatments. Jessica Manson, who is an adult rheumatology consultant at UCLH and has published widely on COVID in the adult population and the hyperinflammation seen with that. And Professor Joe West, who's from the University of Nottingham, an epidemiologist and gastroenterologist there, who's going to talk about some of the usage of big data in assessing survival in HLH. So really fantastic lineup. And so I would like to hand over to Dr. Anu Rao. As I said, she's a consultant hematologist at Great Ormond Street Hospital with a long-standing interest in primary HLH. And she was one of the principal investigators of the novel immune study here in the UK. And she's going to talk today about the post-transplant outcomes in children with primary, so genetic HLH treated with emapalumab. Thank you, Annie, for taking the time today.
Thank you, Claire, for giving me the opportunity. Should I share screen?
Yes, please.
Can you?
Yep, you've started. Yep, that's great. We can see that. Not in the slideshow, but we can see your screen.
I can. Yep. Okay. All right. I'm just going to take my video off because sometimes there are problems with smooth transition from one slide to the other. But I will put my video back on again at the Q&A session.
Perfect.
Right. thank you very much.
And do you want to just put it in slideshow? Do you want to just?
Yes, sure.
Brilliant.
Is that? Can you? Oh, sorry.
No worries.
I'm gonna try again. Screen share.
Yes.
Work?
Still not in slideshow, but it's.
Yeah, I kind of had
maybe
to
you can't.
stop. I tried to do that, but it seems to switch to the other screen.
Okay, no problem. No problem. Thank you. Sorry.
Apologies for that. Just a minute. Let me just. Is this? Yeah, I think we'll just have to move with this.
Yeah, your slides are completely readable.
Readable. That's important.
Thank you.
Readable. Thank you. Okay, so I first of all, thank you very much to Histio UK for giving me an opportunity to present the findings from a phase 2/3 study, which was an open label single arm study using emapalumab, which is a human anti-interferon gamma antibody for children with genetic HLH. The findings of this study have already been published in the NEJM in May 2020. There is a current study that is open and recruiting, which is Novimmune 09, and once again looks at the use of emapalumab in children with primary genetic HLH. There's a little more more efficacy endpoints that have been added on to Novimmune 09 study. Can you see? And this is my declaration. I've been on the advisory board for SOBI and participated in an expert Delphi panel. Can I just stop? Is everyone seeing the slides moving carefully and fine?
Yeah, you're on standard of care.
Lovely. Okay. The current standard of care for HLH 94 and 04 essentially hasn't changed in the last 25 years. We've been treating children with primary genetic HLH on a backbone of steroids at a very high dose of 10 milligram per meter square, which is then rapidly weaned down at 8 weeks down to 1.25 milligram per meter square and stopped, with then a continuation phase which involves alternating pulses of dexamethasone and chemotherapy, which is etoposide, along with the addition of cyclosporin. Children with CNS HLH receive intrathecal therapy. And as you can see, the fundamental approach to treating this disease is profound immune suppression, because we know we have got activated T cells, NK cells, and activated macrophages, which are driving the systemic hyperinflammation and subsequent disease morbidity. The steroids fundamentally are cytotoxic to the lymphocytes. They inhibit the expression of cytokines, and they inhibit differentiation of the dendritic cells. Cyclosporin affect T cell activation and macrophage function, and the etoposide, good old chemotherapy, is cytotoxic to macrophages and induces apoptosis. So this is the way we've been treating HLH for the last 25 years. Now, the question is, what are the challenges with this sort of therapy? And the challenges are fairly broad-ranging, from initially an early concern about early mortality, which is primarily due to systemic hyperinflammation, which remains uncontrolled, and partly due to the fact that you're starting with very high doses of steroids and giving chemotherapy to these children. So there is a significant concern in the early first 2 weeks of early mortality. Subsequently, as you continue to taper therapy, the concerns are around disease reactivation, because we're fundamentally dealing with a hyperinflammatory condition which needs profound immune suppression to maintain control. However, the toxicity of the upfront treatment doesn't allow us to continue with that intensity for prolonged periods of time. So as you taper, sort of in weeks 6, 7, and 8 is when it is classically one tends to see disease reactivation, which therefore requires re-intensification, going back up on the steroids and etoposide. Obviously, the disease is unstable at times biologically, so you may have patients who then transform from complete remission into partial remission status based on clinical and laboratory criteria. The most important problem that we have currently with HLH94 and O4 is for those children who cannot respond or do not respond adequately, what are the salvage treatment options? Should we be just re-intensifying therapy, going up on steroids and etoposide, which adds the burden of treatment-related morbidity, or should we be considering alternative options? At present, the only alternative options we have or ATG or Campath, but neither of them have been systematically studied in a formal manner to try and see what is the response when they're used as salvage therapies prospectively on a study. The other problem, obviously, is pre-transplant mortality is significant. So not many children actually proceed on to have a transplant. And time to transplant is exceedingly important in this disease. The longer you wait, the greater the chances of having disease reactivation and increasing morbidity. And obviously, it all depends on the type of transplant done, the conditioning regimen used, the donor that's used, that influences post-transplant mortality. So the challenges are fairly significant with this particular treatment protocol and requires a huge amount of clinical experience, expertise, close liaising with the infectious diseases team, close liaising with your immunology colleagues to try and see how you can get the patient through to transplant, and obviously with your transplant colleagues to assess fitness for transplant. And this is what a classical clinician would do if you were going to take informed consent for patients on the standard of care and list the risk and side effects that occur with etoposide, dexamethasone, and cyclosporin. And this is what you would take any family through when you're consenting them onto HLH94 or O4. ATG and Campath are often used as alternative first-line options in different countries. The French cohort often use Campath as their first-line treatment option for genetic HLH. But once again, the concerns over there are often around profound lymphocyte depletion and the risk of infections. Obviously, the way you control that is make sure that you don't hang around with patients receiving Campath for too long and you proceed to transplant fairly quickly, i.e. within 4 weeks or earlier if possible. So as you can see, the challenge of treating patients with HLH is considerable. The outcomes, the question is, the challenges are there, what's actually changed in the last 25 years? We can see that the outcomes haven't changed very much on HLH94 or O4, with approximately sort of 50 to 60% outcomes overall survival and progression-free survival. And below, and the table below reiterates once again, there's really no major differences been seen in the mortality that patients experience within the first 8 weeks, the risks of reactivation, the median time to transplant usually being anywhere between 120 to 160 days, and the fact that the CNS HLH is fairly representative across both the studies. So therefore, the question then came, well, what is it that we can actually do about this study, about this particular condition, to actually move things on, to try and improve the outcomes of children with HLH? So an attractive target that came up was emapalumab, which is a fully human anti-interferon gamma antibody, which binds free and receptor-bound interferon gamma. And the question is this a cytokine worth targeting? So in mouse models, neutralization of interferon gamma allowed most of those mice to either survive or to reduce their signs and symptoms. Blocking other cytokines didn't lead to similar results. But it is important to note that there wasn't an exhaustive list of cytokines that were tested in those mouse models. But at least emapalumab, in terms of its neutralization of anti-interferon gamma, did bring about the desired effect. So fundamentally, this was the basis of the O4 study, which was an international multi-center, open-label, single-arm, phase 2/3 study aimed at investigating the neutralization of interferon gamma. The study population with children with primary genetic HLH who either were treatment naive, so treatment up front with a background of steroids, or had failed previous conventional therapy. And in most cases, this was patients who had received HLH94 or O4. And following completion of the study, the patients were entered into a long-term follow-up study. Those were the centers that were involved in Europe and in the United States on the O4 study. Inclusion criteria were children under the age of 18 years with the diagnosis of genetic HLH. They did need to have evidence of active HLH disease. And the decision to actually recruit these patients onto the emapalumab study was very much based on a clinician, individual investigator decision on whether the patients had not responded, had not achieved a satisfactory response, or had actually worsened, had reactivated the disease, or had shown intolerance to previous conventional HLH therapy. The exclusion criteria, obviously, because obviously the concern with interferon gamma is the fact that if you block interferon gamma, you may have an increased susceptibility to infections that are mediated by an interferon gamma response. So obviously patients who had active mycobacterial infections, Shigella, Salmonella, Campylobacter, Leishmania were excluded, evidence of latent TB. And as you can see, the list of the exclusion criteria over there, I won't necessarily read it. So the design of the 04 and the 05 study was essentially treatment with emapalumab for a minimum of 4 weeks, and this could be extended to 8 weeks or longer according to the timing of transplantation. The patients would then enter a follow-up study at 8 weeks and remain on this till 1 year after allogeneic transplant or until 1 year after the last infusion of emapalumab. It's important to note that the emapalumab dosing strategy was to start low and then increase the dose. So starting at 1 milligram per kilogram and then escalating dose to 3, 6, and 10 milligram per kilogram based on the evolution of clinical and laboratory response parameters. Background dexamethasone could continue at 5 to 10 milligram per meter square. Intrathecal therapy was given as appropriate, but it is very important to know that patients who hadn't achieved an adequate response or the investigator felt that they were losing control, patients were eligible to receive etoposide, Campath, or intrathecal methotrexate to further consolidate the response or improve it. So it's an important point to note in this particular study. So in terms of the patient population, 34 patients were treated on the study, 27 had failed standard of care, and 7 were treatment naive. The median age at entry was a year, but the range was from about a month to 13 years of age. 80% of the patients had genetic disease, and all of them had evidence of active disease at enrollment, as highlighted by the HLH diagnostic criteria, laboratory abnormalities, and CNS signs and symptoms. The primary efficacy endpoint was overall response rate at the end of treatment, and overall response was evaluated using both clinical and laboratory parameters as listed over there. Now, in terms, I'm going to take you through a consort diagram, which essentially takes you through the patients and what exactly happened to them. 34 patients were treated, enrolled onto the study. 80% of this cohort had failed standard of care. The remaining 7 were treatment naive. 30 were alive at week 8. 4 patients had died. 3 of them had received standard of care, and 1 was in the treatment naive cohort. And entering the long-term follow-up study, which was at week 8, 28 patients entered that study, and 22 went on to receive a transplant, 19 of which are alive, giving a really good post-transplant survival, which I will highlight to you. Essentially, that's the consort diagram, and then I'll kind of go on to the survival curves for these patients to see. If there are any questions on this, I'm more than happy to take them at the end of this talk. So then the question is, what was the efficacy, the primary efficacy time endpoint being overall response rate, which was a sum of complete response, partial response, and HLH improvement. And specifically in the patients who had failed standard of care, and that's probably the population of interest here, 26% has achieved a complete remission, 30% a partial remission, and 7% had a hematological improvement. So in essence, if you look at the overall survival of the cohort of patients who had received emapalumab, in patients who failed standard of care, 73% of them had their overall survival was 73%, and in all the treated patients, that is the 27 who had failed standard of care and the 7 who were treatment naive, the overall survival was 69%. Now, the causes of death in patients were fundamentally multi-organ failure, respiratory failure, GI hemorrhage, ARDS, and a couple of patients with refractory HLH. In terms of transplant characteristics, because I guess the focus of this talk is what was the post-transplant outcome with with emapalumab, 22 patients proceeded on to transplant. This was a 60-40 split of reduced intensity versus myeloablative transplant. Some of them were fairly high-risk transplants with mismatched or haploidentical donors, and there was some alpha-beta depletion, where 27% of the cohort had some alpha-beta depletion. Survival post-transplant was incredibly good for the patients who had failed standard of care, with a post-transplant survival of 89% and an overall survival for the whole, and then post-transplant survival for the whole cohort of about 90%. In terms of safety and tolerability, which is a really important thing in a group of patients who are incredibly immune suppressed, hyperinflamed, safety and tolerability are incredibly important questions to think about. So in this particular cohort of patients, about 25% of the patients had infusion-related reactions. 53% reported an SAE, and the causes of SAE, as you can see, are listed below: hypertension, pyrexia, infections, and those were the causes of the serious adverse events. Infections. This is again a really important point to highlight, because I think, once again, as I said, the concern with interferon gamma is if you block the activity, you may have an increased risk of infections. It's important to note that 38% of the cohort who entered the study already had evidence of an ongoing infection. The two patients who had infections that were thought related to emapalumab, one patient had disseminated histoplasmosis and one patient had necrotizing fasciitis. Both of them were assessed to be related to emapalumab by the investigators. The other infections were bacteria, viruses, and fungi, all of which is fairly standard and which is seen in a lot of our patients with HLH once they're exposed to excessive doses of dexamethasone. So the conclusion is that in patients who had failed standard of care and were treated on emapalumab, their overall response rate was 63%, and their survival post-transplant was 89%. So the conclusion from our talk and from our study has been that emapalumab led to a significant reduction in disease activity, as assessed by objective and clinical laboratory criteria. It was well tolerated and showed an acceptable safety profile. The neutralization had been proven, i.e. based on mouse models and the fact that pharmacokinetics, which had been done on the study, that there was adequate neutralization of interferon gamma. So based on that, in America, the FDA have approved emapalumab for adult and pediatric patients with primary HLH with refractory, recurrent, or progressive disease. The question right now is in the UK whether this drug will receive regulatory approval, and I think this is something that is actively being discussed and evaluated. And that's it. Sorry, I've kind of whizzed through it. These are the acknowledgements of all the investigators who were on the Novimmune 04 and 05 study. And I'm happy to take questions.
Thank you very much, Dr. Rao. Anybody who has questions, can you please type them in quickly now, and we will hand over to Dr. Claire Booth to go through them with Dr. Rao.
Thanks, Anu. That was great. Sorry, now I've got a bit of an echo. We don't have any questions in the chat at the moment, but I was just looking at your overall survival curves for all of the patients treated, and so the drop is really in that first 200 days. Yes, suggesting to me that it's disease progression is one of the main factors. Can you elaborate on that if that data is available?
So, just making sure that I understand your question correctly. You're saying that the overall survival, the initial drop in the first 200 days, is that right? Sorry, I'm sorry.
Yeah, so that seems to be where most of the steps are, and then it sort of it plateaus out after that, and so that would make me think that it was disease progression played a large role in most of those cases, because actually once they got to transplant, the survival was much better.
Yes, yes, no, absolutely right with that, because I think the patients who died, if you look at the overall mortality in the study, 11 patients died on this study. 8 of them were before transplant and 3 were after. So it pretty much says what you're saying, that, you know, it was either the disease progression or it was, and none of them, and only 2 patients died because of infections related to emapalumab. The rest were all just multi-organ failure, ARDS, GI hemorrhage, which is all part and parcel of HLH, bad disease.
Great, thanks. Okay, we've got a couple of questions through. So the first one is, do you think that the drug could be effective in secondary HLH as well?
Yeah, I think there is certainly a role for it. And I think there is a study that was conducted, which was Novimmuno-6, and that was led by the rheumatologists. And I think it certainly has a role, but I haven't seen data from Novimmuno-6 to actually give you any specifics on that.
Great, and somebody else asked me about your thoughts on emapalumab in an adult setting, which might be a bit of an unfair question. So again, in secondary HLH, if it has a role or a place in the algorithm.
Yeah, it would be nice to see that data, because at least if we see any post-marketing data from the US, which tells us, because the FDA approved it for both primary and so for children and for adults. So actually we should look for data from the US to see what we actually have so far.
I think actually we're in quite a lucky position, really, that we do have a number of different treatment options emerging for these patients. And it is going to be a case of generating the data and looking at it, and through kind of robust trial design to understand which patients are going to be best served with which options. But I mean, as you say, like, nothing had changed for 25 years, and now in the space of the last kind of 5 years, we've got new options coming online, which is fantastic. Okay, I can't see any more questions in the chat. So I'll just thank you very much for a wonderful talk and your time. And I'm going to move on now with a talk from Dr. Alistair Bamford. So as I said, he's the lead of pediatric infectious diseases at Great Ormond Street Hospital, and has really been involved in COVID hyperinflammation in children from the very beginning, being one of the first people to put an alert out for this when the first wave happened. And he's done a lot of work and research and published their findings in the Journal of American Medical Association on COVID hyperinflammation in children. So I'm going to hand over to him. And again, any questions, just type them in the chat and we'll address them at the end. Thanks. Thank you, Alistair.
Thank you very much, Claire. Can you hear me okay?
Yeah, perfect.
I'm just going to share my screen and shift to presenter mode. Is that fine for you?
Perfect.
Thank you. So thank you to the organisers for inviting me to speak today. It's a real pleasure to join you and tell you some more about paediatric inflammatory multisystem syndrome temporarily associated with SARS-CoV-2 and coronavirus disease-related hyperinflammation in children, which can helpfully be abbreviated to PIMS-TS and COVID-related hyperinflammation in children, but also confusingly can be called multisystem inflammatory syndrome in children if you're from the States or other countries outside Europe. And so the talk could also be called MIS-C, COVID-related hyperinflammation in children. So sorry to confuse everyone, but it is slightly confusing, and some of those terms will be interchangeable in the talk. There's my conflict of interests. A further disclaimer is that the literature relating to COVID and hyperinflammation in children is rapidly evolving, and it's difficult to make any conclusions with absolute confidence. And just a search there from yesterday of PIMS-TS and MIS-C, you can see there's over 200 publications in the last 6 months relating to the condition. So quite difficult to keep on top of the literature as well. I'll start off with the acknowledgements, which is that there was a huge effort early on in the identification of the syndrome from multiple teams throughout the UK and overseas. And those collaborations are going from strength to strength, trying to work out what's going on here. And then secondly, within my centre at Great Ormond Street, the infectious diseases team, of which I'm part, are only a very small part of the jigsaw of all the specialties and professionals that have been helping trying to care for these children and work out what's happening in this disease. So for the talk, I'll be giving you some basics on COVID, a Kawasaki disease primer, because there's some similarities with Kawasaki disease. I'll talk about COVID in children in the early weeks and how we identified PIMS-TS as an emerging condition. I'll show you some data where we compared it with Kawasaki disease and toxic shock, and show you that it's truly a multinational problem that's emerged. And I'll then finish with some observational data, thinking about mechanisms and what's next. And that calendar on the right, I update every talk I do just to show how short a time we've known about COVID and PIMS-TS in children. But the crosses, we're gradually finding out more and more with time. So I'm sure you all know SARS-CoV-2 is a coronavirus and of the beta subfamily, which are related to the original SARS-CoV and MERS-CoV, which thankfully weren't as extensive pandemic causing viruses, but also related to common cold viruses, which are listed at the top, that have been around for a long time and don't really cause severe disease in normal hosts. So when we diagnose SARS-CoV-2, this is based on a range of tests and clinical observations like in any other infection. So you can look at contact history and risk factors of disease. We can use PCRs, which are going from strength to strength in terms of sensitivity and specificity, as of antigen testing. We can also look at serology, but that has the traditional limitations of not really telling you whether the disease is acute or in the convalescent phase accurately. And we can look at characteristic picture in the blood, other blood tests and imaging as well to try and conclude whether a patient has SARS-CoV-2 or not. Kawasaki disease is a disease mainly limited to children and young children under the age of 5 usually, and it's diagnosed through a set of criteria, which is classically 5 days of fever with 4 out of 5 of a set of observations such as mucosal membrane changes, conjunctivitis, rash, changes to the hand and feet, and swelling of the lymph nodes, and that's the classic form. But to make it even more confusing, there's something called incomplete Kawasaki disease, which has some or only a few of these features, and can also lead to the result that we're trying to avoid in Kawasaki disease, which is coronary artery aneurysms. The treatment of Kawasaki disease is the mainstay is IVIG and aspirin, and in severe or resistant cases, high-dose steroids and or infliximab. There is a form of Kawasaki disease that involves shock called KD shock, which is very rare, but it's worth mentioning that now as PIMS-TS has some overlapping features with that. So what did we see in PEDS SARS-CoV-2 in the early weeks of the pandemic? Well, from adult data, from adult and child comparison cohort data, this is from ISARIC, you can see that children were very much not on the forefront of the problem in the early weeks of the disease. And there was very, very few admissions and very few sick children in the UK. In adult disease, it was clear that there were some risk factors for severe disease, and these are being used to make risk scores for progression in adult disease, but these weren't really what we saw in children. So internationally, we looked at data from overseas before the pandemic arrived, which really showed that there were low cases of COVID disease in children. Rates of infection seemed to be about similar. It was mostly asymptomatic or mild disease. There was very few critical illness. No risk factors were coming out for severity. The blood picture didn't look like that of adults with severe COVID. And we spent most of our time scratching our heads thinking, why is it that children aren't being affected? This is data from the RCPCH observational data, which just shows from about 300 children that the majority of children admitted with COVID in SARS-CoV-2 in the UK had no comorbidity. But there was a bit of a signal that there were some risk factors such as chronic respiratory disease or neurological disease which increased your chance of being admitted with SARS-CoV-2. The range of symptoms was pretty much exactly the same as in adults for respiratory COVID in the few that had them. And then looking at the severity of disease, you can see that there was very few that required non-invasive or invasive ventilation and very few that required higher than HDU care. And then a whole flurry of publications came out stating this over and over again about how SARS-CoV-2 isn't severe in children. This is a study from a European network set up to study TB that quickly converted to looking at SARS-CoV-2. And they looked at 582 children in April. Note that that's prior to the emergence of PIMS-TS. So this is mostly respiratory COVID, and they found that, that very few required ICU, but of those that did, there was a bimodal distribution with some teenagers being admitted with severe respiratory COVID and some neonates as well under the age of 1 month. So thinking about why the disease is less severe in children compared to adults, there's lots of theories, but no absolute proof yet. There's a suggestion that it could be due to infants and children having a more effective, with an immune system that hasn't succumbed to senescence yet, a difference in the balance of innate and acquired immunity, or the balance of anti and pro-inflammatory cytokines in children, the possibility that they have lots of cross-reactive antibodies or T-cell immunity to coronaviruses due to lots of exposure to the other cold viruses, differences in the state of their blood vessels, and having healthy blood vessels at baseline, and differences in expression of receptors for viral entry. But none of those are proven. The next speakers will talk in detail about the hyperinflammation observed in adults, so I won't talk about that. And in children, they're thought to avoid that first stage, and that the suggestion that MIS-C or PIMS-TS is a late onset, delayed post-infectious reaction to the virus. And so thinking again about why children don't get the acute phase hyperinflammation very often, you can think about differences between the immune system of a child and an adult, and the way in which COVID causes severe disease in adults mainly. So the virus enters through the respiratory tract, and the immune response is either effective and clears the virus away without causing any damage to tissues, or there's an uncontrolled inflammatory response, which, as I said, you'll hear much more about in subsequent speakers, I think. But thinking about children in particular, why that might not happen for them, as I said, there's various theories about expression of viral receptors for cell entry, the differences in the baseline state of the endothelium of the pulmonary blood vessels, and also a different sort of cytokine media in terms of the increased immunomodulatory cytokines compared to a more pro-inflammatory state in adults, but all still theoretical. And while we're all still pondering about that, May happened. And what happened in May was the emergence of this inflammatory syndrome in children. And I'll tell you the story of this based on the emergence of SARS-CoV-2 in London. So this is cumulative cases of SARS-CoV-2 in all people, adults and children in London. And you can see the WHO declared a pandemic around the 10th, 11th of March, and then cases started to increase in London with a peak of the most cases per day around the beginning of April. And then at the end of April, we had a weekend where there were many cases of inflammatory, children with an inflammatory syndrome with multi-organ involvement and no other apparent cause being retrieved by ambulances across North and South London. And this was enough for us to call an urgent meeting with relevant stakeholders, including NHS England and the Royal College of Paediatrics and the PICU societies, to put out an alert to raise awareness of this condition, to report cases and to try and work out what was going on. We did a very detailed examination of a first sort of 27 or 8 cases from across the UK, and it ultimately contributed to an RCPCH statement relating to try and identify what this condition was and to give it a name. And unfortunately, this is the name that was come up with that wasn't the most easy thing to say, but the reason for it being quite so clumsy is that we didn't know what it was. We didn't know whether it was caused by SARS-CoV-2 or not. We didn't know whether it was a condition that we already knew that was emerging or a different infection that was emerging. So we had to be very broad and just say it was temporarily associated with the emergence of SARS-CoV-2 till we knew what was going on. So PIMS-TS was born. And as I say, the purpose of the case definition wasn't to be a sort of ultimate final case definition of the new syndrome. It was to be a catch-all for hyperinflamed children in the UK and try and look at them in detail and work out what was causing this hyperinflamed condition and how we can characterize it further. I won't go into detail, but this is the RCPCH definition, which is a child with persistent fever and hyperinflammation affecting one or more organ system, exclusion of another microbial cause. And this is important that the PCR for SARS-CoV-2 could be positive or negative. And I'll talk a little bit more about that now. So I said we looked at these first sort of 27 cases in detail, and what they came out as having in common was fever, rash, conjunctivitis, abdominal symptoms, and headache. When we looked at the clinical features, something that they all had in common was shock, myocardial dysfunction in a subset. A smaller subset had coronary artery dilatation, which is something we'd only ever seen before in Kawasaki disease, and a rare sort of vascular disease. And bowel inflammation seemed to also be present in a subset. And then looking at the characteristic blood tests, this is what made us really think this is related to COVID, because it was almost exactly the same as we saw in adults with severe COVID, that being low lymphocytes, very high inflammatory markers, raised ferritin, fibrinogen, D-dimers, and raised cardiac enzymes. So we really thought this probably was linked to SARS-CoV-2, but the PCRs was usually negative no matter how hard we looked, and the IgG was positive, suggesting it was a post-infectious phenomenon. Later on, the CDC, about two weeks later, created their case definition based on cases emerging in New York and across the states. It's very similar, but was given a different name, MIS-C. Extended the diagnosis up to 21 years of age and had much more of a dependence on a proven epidemiological or laboratory evidence of SARS-CoV-2 infection. WHO and ECDC produced their definitions the subsequent day, the WHO definition again being similar to that from the US, with extended age range and more strict reliance on proven on a highly likely SARS-CoV-2 infection. So Claire mentioned this rapid publication that we worked on with a team from Imperial and also from Evelina and a team from the States that worked many years on Kawasaki disease, where we looked at more detail at 58 children ranging the spectrum. And we compared these children with PIMS-TS with a historical cohort of children with Kawasaki disease shock, and also toxic shock syndrome to see what were the similarities and differences. And some really became apparent quickly, which is that these children are older, sort of in the average age of around 9 or 10. They had higher white cell counts, neutrophils counts, lower lymphocyte counts. And in terms of biochemistry, their CRPs tended to be higher, albumins lower, ferritins, troponins, and D-dimers higher. So they seem to be a distinct phenomenon to our historic Kawasaki and toxic shock syndrome cohort. This slide I just put up just to show the sort of temporal relationship between the syndrome, with this green line represent the sort of beginning, peak and end of PCR positive cases in the first wave. And then this was the beginning, peak and end of the first wave of PIMS-TS that we've had as well, just showing this temporal relationship in the UK. Subsequent to this, we've had several publications coming from the UK looking at the sort of multi-organ involvement here, and the cardiac involvement was very clear, at least in the acute phase. This is a study from Birmingham where they've looked at 15 patients, all of who were admitted to PICU with GI symptoms, as I mentioned, but also raised cardiac markers and ECG and echo abnormalities, including coronary artery dilatation, valve dysfunction. All of these children were treated with IVIG and steroids, and they're going to publish longer term outcome data soon, I think. From the GOSH, we had a very small case series of neurological presentations associated with PIMS-TS, with 4 children with neurological signs and symptoms, which seemed to be of a characteristic mixed CNS and PNS involvement. There's a slight signal that there could be a signal change of the splenium of the corpus callosum, which could be associated with this condition. And we postulated various mechanisms, including possible relationships to cytokine storm macrophage activation, but all very theoretical. The GOSH team have also looked at renal dysfunction, not just of PIMS-TS, but of SARS-CoV-2 infection in general, and found AKI to be very common, especially if a child was admitted to PICU, and a predominance of patients with PIMS-TS also having AKI. But none of them had a biopsy or it required renal replacement therapy, and all of them improved after the acute phase. So the renal team have proposed that this is mainly hypovolemia and hyperinflammation. The Evelina team have published a case series of imaging findings, and the most characteristic things I think to note are that the chest x-rays are frequently normal. There are some children that have coronary artery dilatation, and on abdominal imaging, both CT and ultrasound, there does seem to be this characteristic right iliac fossa inflammation, terminal ileitis, which has been confused with appendicitis in quite a few case series. So just broadening the picture a bit more, just to show that UK wasn't alone. France saw similar cases emerging, and you can see the map of COVID and PIMS-TS almost perfectly match. And again, this recurrent theme of the emergence of CoV-2 and then the emergence of PIMS-TS subsequently. And then the same story again from the US, with case series from the New York states, and then from across the US, with again this picture of SARS-CoV-2 emerging, then PIMS-TS whenever it's looked at. So really strong epidemiological evidence that they're related. Going back to the UK, the PICU teams who have been very involved in the management of these children have published a series from nearly all the PICUs in the UK, looking at 78 patients. Their main findings are that most of these children had no comorbidity. They were older than previous inflammatory kids with Kawasaki disease. They're 11 years old with a preponderance of Afro-Caribbean and Asian children. Only 20% were PCR positive, but most of them were serology positive. And this graph that they've published just shows you the cumulative number of patients of PIMS-TS compared to historic data on hyperinflamed children, including macrophage activation and severe Kawasaki in previous years, just showing that there was a real surge of hyperinflammation. This graph from the same paper also just shows you how these patients were managed over time, April to May, increasing use of IVIG, steroids, and then biologics being used latterly in the first wave. So what do I think what's happening? Well, I can't claim that I know what's happening, but I can present some theories. Going back to this graph about this being a late stage immune-mediated response to SARS-CoV-2 infection and thinking about that, there is a suggestion that from SARS-CoV-2, from the virology world, that the SARS-CoV-2 is acting like a superantigen in much the same way as maybe toxic shock is seen. However, Judith Brewer and team from the virology team have looked at the genotype of many SARS-CoV-2 viruses in the community and compared it with those from children with PIMS-TS and children with SARS-CoV-2 that don't have PIMS-TS and haven't seen any new or unusual polymorphisms associated with PIMS-TS. So I think the jury's still out on that. In terms of immunophenotype, there's been a flurry of studies, sort of 3 or 4, which I'll just briefly mention about the immunophenotyping of these children. And this is the first paper that came out from the Evelina group by Mickey Carter and colleagues, and they've looked at 25 patients compared to 7 healthy controls. They've looked at serology, immune phenotype, cytokine profile, and they found that the serology is predominantly IgG against SARS-CoV-2, suggesting later on a post-infectious problem. They've looked at the immune phenotype and shown lymphopenia, immune activation, and possibly impaired antigen presentation. They've looked at detailed cytokine profiling, showing a range of inflammatory cytokines are raised in children with this condition. But importantly, they've looked at 3 time points and shown that nearly all of these things go back to usual in the normal in the convalescent phase. And they've looked at historic data on KD and proposed that these are very different from what you see in KD or Kawasaki disease. This is another collaboration between a Swedish and Italian group where they've looked at SARS-CoV-2 infected children, healthy children, children with KD, and MIS-C children. Note that it's always very small numbers in these case series. This is 13 children, and they've compared with adult COVID as well, which you'll be hearing about next. And what they found by looking at using techniques such as principal component analysis is that the kids with MIS-C and Kawasaki disease have a different unique protein expression in blood compared to adults with severe COVID, be that on ITU or not. They've also looked at immune phenotype, and again, I won't go into it in detail, but showing that there's a sort of a distinct immune phenotype of the MIS-C patients in grey here compared to Kawasaki disease patients, and again, a different cytokine profile, grey being MIS-C and pink being Kawasaki disease. But again, stressing that this is small numbers and a very large range of analytes that have been looked at. So we have to be cautious in conclusions based on this. One interesting observation that they've made is that they've looked at baseline immunity to other coronaviruses, so the common cold type coronaviruses, and found that kids with MIS-C seem to have no underlying baseline immunity. However, we need to think about the fact that these are older children than the other historic cohorts, so or the other disease cohorts, so that may be just a sort of non-pathogenic observation, but interesting nonetheless. And then they've also looked at a huge range of candidate autoantibodies and found some that are unique to MIS-C compared to other inflammatory conditions and in SARS-CoV-2. So again, with autoantibodies, not sure whether it's a cause or effect of the condition, but again, watch this space. This is quite a similar paper from a team from New York looking at 9 children, where they've looked at a MIS-C compared to some control patients, and they've done a similar range of investigations. So they've looked at immunology, the IgG to SARS-CoV-2, cytokine profiling, immunophenotype, and autoantibodies. So pretty similar approach scientifically. but they've again shown that there's a unique antibody profile to MIS-C. They've shown that the cytokine profile and immune phenotype also seems to be unique. And they've also proposed a range of candidate autoantibodies that may be relevant to the condition. And then finally, this is the most recent paper, again from a New York team, where they've looked at antibodies to SARS-CoV-2 and compared it from children with MIS-C, children with SARS-CoV-2 without MIS-C, and adults with from convalescent plasma of mild disease or adults with severe COVID, and shown that there are differences between each of these groups. But the main findings being that there's a distinct antibody response in children compared with adults. They have less anti-N, so that most assays look at the spike antibody, but there's anti-N antibody as well, and they seem to have less of that in children. So and then there's also less neutralizing antibody in children as well. But I think one of the most interesting findings from this study is that there wasn't really much difference in the antibody profile from children that had SARS-CoV-2 that had MIS-C and those that didn't. And when we're thinking about the mechanism and whether the antibodies that are caused by SARS-CoV-2, that are SARS-CoV-2 specific, are causing the MIS-C, then this might be a clue that they're actually not the main culprit. Bigger data sets have come out across the US, where they've taken 570 patients with MIS-C and analyzed them using another technique called latent class analysis to divide them into clinical groups. And they've found that there's one group that would be MIS-C with the multisystem inflammation, characteristic bloods and shock that don't really overlap with the other phenotypes. They've seen kids with acute COVID with multisystem inflammation, which sort of mirrors the adult severe COVID disease you're going to be hearing about next. And then there's a group that seem much more like Kawasaki disease, making us think that maybe there is sort of different cohorts of patients and that the ones with KD maybe aren't the ones with MIS-C, but I think the jury's out there. Data from ISARIC of a similar nature is pending, so watch this space. So finally, trying to put that all together about what I think is going on, I think we need to take a step back and just think that we actually haven't proven the Bradford Hill criteria about SARS-CoV-2 causing MIS-C or PIMS-TS yet. So we need to make sure we're gathering evidence for that still. But thinking about the hyperinflammation in children, I think the majority of children get SARS-CoV-2 and don't get any hyperinflammation at all. There's a cohort of children that will go on to get severe primary COVID with hyperinflammation in the adult phenotype, and this tends to be older adolescents with other risk factors that are similar to adult severe disease risk factors. And then down the line, we're getting children that have PIMS-TS, and we're also getting children that are getting classic Kawasaki disease, which may well have been triggered by exposure to SARS-CoV-2. But also to remember that each of these can prevent with features of macrophage activation or HLH, and that there's overlap between each of them as well. So it's a bit of a murky picture, but we're trying to work out the best sort of diagnostic criteria we can. In terms of treatment, we went through a Delphi process because there was an absence of evidence, and this involved multiple specialties across the UK and multiple different specialty expertise groups. And there seemed to be equipoise in terms of management with IVIG and steroids, biologics used for refractory disease, and common consensus that aspirin and thromboprophylaxis should be used. And recovery trial has been modified to include children and to try and answer the question comparing IVIG, steroids, and subsequently biologics. So watch this space for that as well. We've got about 40 recruits now into recovery trial. So again, just taking a reality check about how common this is, it really is very rare. If we think about the seroprevalence of SARS-CoV-2 in children, this is data from very early in the epidemic when the seroprevalence in the people under 20 was thought to be about 5%. So it's probably a lot higher now. So huge numbers of children would have been exposed and had no untoward effects from SARS-CoV-2. If we look at death rates from all cause and unintentional injury, lower respiratory tract infections, then deaths due to COVID or PIMS-TS are very small compared to deaths due to other causes in the UK, and similar to that from influenza. So it's very rare. And my final message that I try and have the main take-home message to everyone now is that don't miss other differentials, because I think we're all very fixated on trying to work out whether kids have PIMS-TS or not. But I've already seen cases where bacterial infection has been the main thing that's been driving it, viral infections, including severe CNS viral infections, disseminated severe fungal infections, and rheumatological conditions that have all been initially thought to be PIMS-TS, and where high-dose steroids and such have been considered as first-line options. And obviously these can have risks in the context of any of these diseases. So I think we need to be really careful we're not overdiagnosing, especially with rising seroprevalence. Huge unknowns, as I keep saying. I won't go through the list in detail, but all of these studies are trying to work out what's going on and the best way to treat the illness as quickly as we can, ready for the second wave, which is looming, I think. If we're thinking about implications for vaccination of children and young adults, I think it's wise to take stock, but I think that is not an argument for not including children and young adults in vaccine trials. And we definitely should be doing that. And that data about the similar serology in children with MIS-C or COVID is reassuring that we'll probably be okay. There are two studies that are rapidly looking at how we can treat these kids best in an evidence-based way. Our next speaker is going to talk about adult hyperinflammation, but just to say there's also MIS-A now. MIS-C has now progressed into the adult range, and there's cases from the UK, overseas, and this is a case series which you may hear about in the next talk of MIS-A in patients from the UK and adults. So thinking about what I think are the most important things to think about now, I think we definitely need a better name. And a unified name and unified diagnostic criteria. I think we won't have a diagnostic test anytime soon, and it will be very much like rheumatic fever, toxic shock, macrophage activation, where we have a set of diagnostic criteria rather than a set diagnostic tests, and we need to get used to that fact. This is very likely to be a part of the range of manifestations of SARS-CoV-2 in a similar way that we see a range of manifestations to flu or group A strep or a whole range of other infections. And I think we need to really work on serology and the meaning of serology like we do in other infections, thinking about can we use titers, avidity, IgM versus GA and GNA to work out whether someone's got acute or recent or convalescent infection. So I'll finish there. There's a summary of what we've covered. It's a bit of a whistle-stop tour, but as I say, there's 230 papers that I've tried to sort of get the key bits out of, and I hope I've introduced you all to the syndrome adequately. And I'll finish there and take any questions. Please do email me, or I'm trying to use Twitter, so you can try and tweet me or something if you want to.
Thank you very much, Dr. Bamford. Please, in the audience, get typing with your questions now as we hand over back to Dr. Claire Booth.
Thanks, Alistair. That was like the most super clear talk I've ever heard on SARS-CoV-2. So actually, Matt Collin has asked the question that I was going to ask. So he says, wonderful talk, Alistair. Is there any association with recently reported loss of function genetic variants in interferon signaling? So, you know, what's been published now in the adult world, has that? I imagine
very good question, and I don't think anyone's done it yet, but I think people will be doing it very quickly. I'm not personally, but I know I haven't seen any data published on it, but I think that it will be a very important thing to look at.
Yeah. Has there been any data published in the pediatric populations about like genetic predispositions or anything? Not that I've seen that's been specifically based on pediatrics, and I haven't seen anything on that. But Diamonds is a study looking at RNA expression in the acute phase, so we'll get some data on that. There are a subset of ISARIC patients where they've taken DNA, so I presume there'll be a group from ISARIC that will be looking at host factors as well. Yeah. And I know that the Casanova lab have been reaching out to various groups in the UK to collaborate on both of those studies. So I'd hope that we get collaborative and joined up working looking at that host susceptibility. Yeah. Well, that was a really fascinating overview of how the situation's evolved, and I think we do forget like how short a time it's been really to have got all of this data already. I can't see any more questions on the Q&A. So I think this moves us very seamlessly into hyperinflammation in adults. So I'm just going to thank you, Alistair, so much for your time and a fantastic presentation. I'm going to hand over to Dr. Jessica Manson, who's a consultant adult rheumatologist at UCLH. Again, who's had an interest in hyperinflammation and HLH, possibly in relation to COVID, over the last few months. So thank you very much, Jessica, for taking the time to talk to us.
Hi, can you hear me okay?
Yeah, perfect. And I can see your slides beautifully.
Excellent, great. So hello everybody, thank you so much for having me today. Thank you to Lynn for organising it, and thank you to Claire and to Matt for introducing me to Histio UK in the first place. So I'm going to talk about adult disease, predominantly focusing on HLH actually, with a fairly brief nod to COVID. So the first thing I want to convince you of is that we have a problem. The problem that we have currently is that in the adult population, at least, HLH remains a very under-recognised syndrome. My colleague and friend Jo West is going to talk next about some up-and-coming UK epidemiology data. But one of the problems is that we have multiple and invariably terrible names for the same thing. We also have really very little good evidence about how to treat HLH in the adult population. Almost everything we have is extrapolated from paediatric data. And this all matters because the outcome is absolutely terrible in some cohorts. So if you get to intensive care, you have a hematological malignancy driving your HLH and you're an adult, then you have an 80% chance of dying, which is fairly shocking, clearly. And even at the best end, where you have an established rheumatological driver of your HLH, such as adult onset Still's disease, where you're known to your team, when you can be followed up longitudinally and see the gradual dip in your health, still the outcome is poor. So first of all then, what is HLH? So HLH stands for Haemophagocytic Lymphohistiocytosis, and I realise that I'm talking to a fairly mixed group today, some of absolute HLH enthusiasts who, like me, eat and drink it, but also some people who maybe know very little about it. So one of the problems we have, as I've mentioned, is that HLH, I think, increasingly is widely accepted to be probably the best term, but within secondary disease, we also have synonyms such as macrophage activation syndrome, which is the HLH of rheumatology, macrophage activation-like syndrome, which is the HLH of sepsis, pretty much, and a number of other similar terms. The upshot, though, is that what you have is a hyper-inflammatory state. Anu's already talked about primary HLH, and I'm going to focus on the adult population, where we have three main drivers: hematological disease, largely hematological malignancy, lymphoma in particular, infection, including COVID, and in the developing world, infection, particularly EBV and HIV, are still the main drivers of HLH, and rheumatological disease. And in rheumatological practice, the most common driver numerically is probably lupus, because lupus is not very rare, but the biggest risk is amongst the population of children with systemic JIA, or the adult version of the disease, adult onset Still's disease. We must remember, however, that some people with primary HLH do manage to get through to adulthood without being diagnosed. So we've recently at UCLH made a diagnosis of primary HLH in a man in his 20s who had managed to get to that age without presenting, and even managed to have a spell in prison, which I think is fairly sporting given the infection risk probably there. So we mustn't forget primary HLH in adults, but it's rare. So the defining characteristics of the clinical syndrome of HLH are fever, and that it's extremely bad for you. So there's a high mortality, as we've discussed. There's a risk of multi-organ failure, hemorrhage, sepsis, all of which can kill people. And the other well-known defining characteristic is hemophagocytosis by macrophages. And I'm going to come back to that in a minute because I'd say it's fairly thorny. So would you think of HLH in all these cases? And I'm hoping that by the end of the talk, I will persuade you to do so. So these are cases we've had at UCLH in the last year or so. A 24-year-old woman who presented, was not known to have adult onset Still's disease, but presented with fever, a sore throat, and lymphadenopathy, and then to a DGH just outside London, and was transferred to UCLH with what was thought to be lymphoma and full-blown HLH. In fact, it turned out she had adult onset Still's disease. Her HLH was bad enough for her to require intensive care admission, to be transferred to Barts for ECMO, But having said all of that, with treatment, she is now back working full-time as an accountant and running 5K 3 or 4 times a week, putting us all to shame. The second patient is a woman who had an apparently uncomplicated total knee replacement for osteoarthritis following an early childhood injury. She had accelerated osteoarthritis. She then presented 2 weeks later with fever and a sort of septic shock picture, was seen by my infectious disease colleague, Sarah Logan, on intensive care, who asked the question, does this patient actually have HLH, which indeed she had. She responded very quickly to treatment, but unfortunately, although she survived, has been left with post-traumatic stress. I don't blame her. The next was a 35-year-old man presented with seizures following a 6-month history of a PUO. He was a roofer. Thankfully, he didn't have a fit on a roof, but he won't be going, although he also survived, he won't be able to go back to work because sadly he developed bilateral vitreous hemorrhages and is now blind. The last patient died, and he was in this very tricky position of having graft versus host disease and then also HLH complicating. So how do we diagnose it? I'm just going to take us back to basics for a minute. So the primary clinical feature is of fever, but remember these patients are often extremely unwell and they'll be on antipyretics, and often also on a filter which clearly masks fever. So instead you'll have to use things like persistent inflammatory markers to give you the clue. Patients have hepatomegaly, splenomegaly and lymphadenopathy, and they can bleed. So the patient whose hand you see is how I got really interested in looking after patients with HLH in my final year as a registrar about 12 years ago now. And as you can see, she's bleeding into her skin. They also present with neurological features such as confusion and fitting. And in fact, in our a national HLH group, HASC, which I'll come on to in a minute, one of my neurological colleagues presented yesterday all the possible neurological manifestations of HLH, which are numerous. So in terms of the tests, it's about pattern recognition, and I'm going to show you that pattern again in a moment, but it's very unusual to have HLH without having a degree of thrombocytopenia, and often untreated, these patients will go on to have 3-line cytopenias. Associated with that, more commonly in adults than in children, you see a transaminitis, and then you see a paradoxical rise in the CRP, but a fall in the ESR. So it's one of the very rare occasions where I still request an ESR. You see coagulopathy, which alongside the thrombocytopenia is the cause of the bleeding, and a high LDH. So those are things that as a medical registrar, you would probably request as standard. The things that you might not request, and which I'd like you to add to your panel of sick patient review tests, is to check for a ferritin, and I'll come back to the detail on that in a minute, but a very high ferritin should make you think about HLH until proven otherwise. Alongside the high ferritin, you get high triglycerides, such that the serum is so lipemic that sometimes it can't be processed routinely in the laboratory, and again, you get falling fibrinogen. Soluble CD25 is a good marker of HLH, but is often not very practical in that it takes some time for it to come back. So don't wait for the return of that kind of test. And that also has to be sent off usually, well, in our area to Great Ormond Street. It is, though, useful to assess patients when they get better to see whether they're at risk of further episodes. And then haemophagocytosis on the marrow. So what's actually happening in HLH is that you're having a lack of the usual control. So what you have is some kind of stimulation of your immune system, either by hematological malignancy, infection, or a rheumatological disease. And then whereas this would usually either be controlled by clearing the virus or dealing with the cancer, you get an uncontrolled activation of T cells and macrophages. And at some point, the patient will move from indolent HLH, which they can kind of just about cope with without crashing in a heap and needing ventilatory support and inotrope support. They will move from there into the full-blown cytokine storm. And by this time, the mortality goes up significantly. So what we're trying to do is to work out how to recognize this patient group when they're still in the indolent stage, where you can intervene with less toxic drugs and improve outcome. So one of the things to understand actually is that it doesn't matter if your HLH is driven by COVID, by a lymphoma, by Still's disease, or any other driver you can think of. It pretty much looks the same. And this is the group of blood tests which I find really helpful to look at together. So what we see is this is the same patient just before and after tipping into from the indolent to the cytokine storm phase of HLH. So what you see is he has a pretty sporting ferritin in the first set of blood tests. In this point, he was actually perfectly well, chatting to me on the ward with what turned out to be adult onset Still's disease as the cause of his HLH. You'll see he has a stonkingly high ferritin, a high fibrinogen, raised triglycerides but not very, a high ALT but not very, and you might and a normal platelet count, but I would argue an inappropriately normal count. Normal platelet count for his high ESR, because we would normally expect the platelets to be up in that situation. What you see in the second set of blood tests is what happened when he fell into the cytokine storm phase of HLH, and by this point was now requiring inotrope support and ventilatory support, and you'll see the ferritin has gone up significantly, and with it fibrinogen has crashed, ESR has crashed, platelets are falling further. And really the question here is, would the patient in front of you benefit from immune suppression? Now, there are diagnostic criteria to help with that decision making, but I think I've often seen things go wrong a little bit when we wait for patients to be ill enough to necessarily fulfill particularly the 2004 HLH criteria, which are extremely useful in paediatric management. But as I said, they were the criteria were from studying children, not from adults. So we've extrapolated them into adult practice. I always think it's quite interesting to look in contrast at the 2016 criteria for macrophage activation syndrome in children with systemic JIA, and you'll see it's much easier to meet those criteria, and that's because of the background established risk that systemic JIA brings. The H-score is extremely useful in practice and can be found in this website, and gives you a percentage of the patient chance of the patient in front of you having HLH. So I apologise in advance to all the haematologists on the line, but this is how I understand hemophagocytosis. It is not a binary thing. So it is not uncommon to see some degree of hemophagocytosis on the marrow in a patient who does not have HLH. But the absence of hemophagocytosis does not exclude HLH. And I have seen this, people fall foul of this so many times. In fact, the man in his 20s who was recently diagnosed, as I mentioned, with a primary HLH, with a perforin deficiency, had several bone marrows before hemophagocytosis was identified. So if ever we needed proof that no hemophagocytosis does not mean no HLH, he is that proof. So why do we don't bother to do one? Well, the in-bracket reason is part of it, which is sometimes, even in an institution like mine, where HLH, I hope, is increasingly in the front of people's minds, we still do need to sometimes convince people that the patient has HLH. By the way, we don't always just find it on marrow. We also sometimes see it on spleen or liver biopsy. But also we do the bone marrow to look for the driver of the HLH to help us make the diagnosis either of malignancy or infections such as leishmaniasis might be seen on the marrow. So the key thing about hemophagocytosis, as far as I see it, is that the bone marrow shouldn't, the result of the bone marrow shouldn't replace your clinical judgment in either direction. So ferritin's really useful. It's cheap as chips. It's quick to get back. But whereas in the pediatric population, a ferritin of more than 10,000 is highly suggestive, almost specific for HLH, that's not true in the adult population. So there are other differentials such as paracetamol overdose that will give you a super high ferritin, and also in people who are transfusion dependent, who have hemoglobinopathies. It's also important to know that an only moderately raised ferritin doesn't mean that the patient doesn't have HLH, sorry, lots of negatives. So I always think particularly of a patient I had who had horrendous HLH complicating lymphoma and who sadly died, but he never had a ferritin of more than about 3,000. So it is useful in that it's inexpensive and it responds rapidly to treatment. So we did a study across, I'm going to come back to what HASC is, you'll see this mentioned in a few of my slides, but HASC is the National HLH Cross-Specialty Collaboration, which I co-chair with a Sheffield rheumatologist, adolescent rheumatologist called Rachel Tattersall. And Effen Sen, who is a paediatric and adolescent rheumatologist in Newcastle, led a project looking at what a ferritin of more than 10,000 means in UK practice. And he has matched paediatric data, but this is a summary of the adult data. And the take-home message is that ferritin of more than 10,000 is really bad for you. So about 40% of the patients died. But also we are missing a lot of HLH. So of the 408 patients that were looked at, the assessing doctor coming and looking with their HLH hat on thought that about 70 of these patients had HLH, but only 50% of those were diagnosed by the treating team. So the link between COVID and HLH. So there's been a lot of controversy in the literature about the term cytokine storm syndrome, perhaps triggered by HASC and Fujimeta. We wrote a letter very early on in the pandemic where we suggested that people need to consider the possibility of cytokine storm syndrome complicating COVID. And I have definitely moved towards using the phrase hyperinflammation, which gets away from people having to measure cytokine levels and decide whether it is a storm or it isn't a storm. But again, the question is, should a patient be immunosuppressed? That's really the question. So if we think about the overarching term of hyperinflammation in general, then we've talked a little bit today already about primary HLH, and within secondary HLH, which I'm talking to you about now, there is definitely a recognition that SARS-CoV is a potent driver of HLH. In the sepsis literature, as I've mentioned before, this had been called macrophage activation-like syndrome historically. But SARS-CoV also causes a syndrome all of its own, which I'm going to mention briefly in a minute, which is the one that all of you medical registrars out there will recognize very well, which is the lung dominant hyperinflammatory syndrome triggered by COVID fairly commonly. And then the other cytokine storm syndrome or hyperinflammatory syndrome that we recognize is the cytokine release syndrome associated with CAR T-cell and other therapies. A nod to this group, and it's worth looking at their website. CTAG was set up to try and respond to the clamour for advice about how to treat COVID patients early on in the pandemic. This is a group of pharmacists and medics who've tried to collate and continue to update the information on evidence regarding treatment for COVID. So the way that I think we should think about COVID and hyperinflammation is that there is a subset, that there are subtypes of hyperinflammation caused by COVID. So as Alistair mentioned, we published through the HASC collaboration with Joe West, who's about to speak, and Rachel Tattersall and Matt Collin, who I think is also on the call. So this is what HASC is all about. In that list, you've got a rheumatologist, a hematologist, a gastroenterologist, and an epidemiologist. We also had intensive care doctors and others. So what we described was really the clinical observation that if you have a markedly high CRP and a moderately elevated ferritin, which made a phenotype that we called COV high, that you were at higher risk of, this was associated with a higher risk of needing ventilatory support and of dying. And that if we could begin to recognize this as a syndrome, we could start to put in place the required treatment earlier on, but also that we could help to stratify interventional trials properly to try and reduce the risk of negative trials in this area. So COV high is a syndrome that I certainly didn't recognize before, and neither did my infectious diseases colleagues. Whereas COVID can also cause a number of syndromes which we did recognise before, such as HLH, such as forms of vasculitis, such like good pastures. And then Alistair has covered beautifully the development of this characterization of this syndrome, PIMS-TS. And we've also had multiple publications regarding the neurological inflammatory disease. And then more recently, the focus on long COVID and chronic fatigue. And it'd be very interesting to see how these do or don't link in with hyperinflammation. But this talk is really to focus on HLH, and what I'd like to show you is some data which has been led by Luke Flower, who's an anaesthetist, and by Vanessa Crick, who is an adult rheumatologist, and represents describes the 11 patients that we, between us at Sheffield, UCLH, and Luton and Dunstable, these 11 patients developed HLH as a complication of COVID in the first wave. So a number of things to show you. The average age was 40, and you will see that 4 of the 11 of these patients died. They all had proper HLH as defined by a high H score, and many of them had an underlying chronic condition such as hematological malignancy or rheumatological disease, which I think supports the idea that in adult practice that often there's a sort of multiple hit. So you have some sort of underlying illness such as lupus, then you get a viral infection, and then that triggers your HLH. So this is soon to be submitted for publication. How do we manage it? This evidence-based algorithm was published by Stuart Carter, a rheumatologist in Sheffield, and Rachel Tattersall from Sheffield in 2018, and I'm pleased to tell you that it's already out of date, which they would completely admit. We have, as I've mentioned before, and I'm very jealous of Anu and all her evidence, because we have very little evidence about how to treat this in adult practice. We do have some evidence about how to treat HLH that complicates rheumatological disease, but what do we actually do? So what we actually do is we use, tends to be in rheumatological practice, we use methylprednisolone, whereas in hematological practice, they use dexamethasone. We use IVIG, which is expensive and a rare resource, and increasingly we are now using anakinra. And the bit of this, which I think is out of date, is that anakinra is often now first-line treatment, and certainly at UCLH, we're fortunate enough to have had agreement to fund anakinra. We use sometimes quite high doses intravenously. And then the third line treatment remains etoposide, and this should always be used with discussion with a hematologist. But the trouble is that we still have problems with all the drugs that we use. So steroids are nothing but trouble. IVIG, as I said, is expensive and a scarce resource. Anakinra is useful if you can get it, but there's actually no randomized controlled trial evidence in HLH all comers, and also there's only some hospitals in the country where you can get it. And etoposide is associated with neutropenia and with secondary infections. So really on the back of all the problems that I think I've hinted at, in 2018, Rachel Tattersall and I set up HASC, which is about to be renamed HiHASC. HASC is the HLH across specialty collaboration. And the aim of this was, in essence, to try and reduce the deaths associated with HLH. And our aims can be divided into 3. So the first is clinical. So we are encouraging the establishment of multidisciplinary teams, if not in each hospital, then certainly each region, to manage HLH. And we are linking these MDTs together to try and share learning and share experience. Every patient is difficult and complicated, and management of them should be a team sport. We are working hard to try and improve access to drugs and to ensure that there is fairness, that you can get anakinra wherever you are. We have produced guidelines to help manage, for instance, in the COVID trials, HASC was turned to by Recovery and others to provide advice on how to safely give immunosuppressive drugs in the context of trials. We've been giving lots of talks, and we've published lots of articles to try and spread what information we do have about HLH and certainly how to recognise it. And we are really, our aim is to end up with proper trial evidence on how to treat secondary HLH. But we've also already done some research, for instance, Effen's study about highly elevated ferritin. Joe's about to talk about some epidemiological work, and Matt Collin has been pushing through a national registry. Sorry. So my penultimate slide is just to try and persuade you of the merit of having an HLH MDT in your area. So this slide is UCLH incidence and death or survival from secondary HLH. So the red arrow shows you when UCLH MDT began, and the yellow arrow shows you when HASC began. And I hope to be able to persuade you that we have an excellent graph describing ascertainment bias here. So what happened is that as we've all become more and more obsessed with HLH at UCLH, we've begun to diagnose it more. So it was always there, I am sure of it. It's just that we didn't know before. And then very excitingly, just in the last year, we have switched so that we used to have many more patients dying than living. And that has changed in the last year, which is fantastic. And I thank Dalia Ludwig and Beth Goulden and Pooja Mehta for helping me make the UCLH MDT work so well. So my last slide is my acknowledgement slide. So Rachel, I've mentioned, Prof. Liz Jury is an immunologist who I've worked with for many years, who helps me think about ideas, scientific ideas. And I'd like to massively thank Lynn Jackson and Histio UK for supporting Rachel and me in our crazy idea of trying to get people around the country interested in HLH, which is such a terrifying condition to manage. I'd also like to thank Vanessa Morris, who I hope is on the call, who's a colleague and friend of mine in UCLH rheumatology. And everybody needs somebody like this to make you brave and try and encourage you to stick your head above the parapet. All the team, my team at UCLH, and all of the HASC members who've gone from about 30 to over 200 since COVID. Thank you.
Thank you very much, Dr. Manson. We do have some questions coming in. Please submit them now if you have additional ones. Over to Dr. Claire Booth.
Thanks, Lynn. Thanks, Jessica. So Laura Aspo says there's 3 questions really, all on the comment. Laura Aspo, great talk. Have you ever seen HLH secondary to PMR without large vessel vasculitis? Because she thinks they have a patient.
I think that you can, hi Laura, by the way, I haven't seen you for ages. I think that you can see HLH secondary to any inflammatory condition. So I have never knowingly seen it secondary to PMR or large vessel vasculitis in fact, but I think that you can, it doesn't really matter what the insult is, that's the point. If you have an activated immune system which just fails to self-regulate, then that's good enough.
Great. Actually, yeah, so this is a very good question. So how do you, in somebody who's persistently spiking fevers with sepsis, how do you determine whether this is sepsis related or evolving HLH?
It's a nightmare, that's the truth. You get better at it with the more that you do, and you work as a team. So you bring your infectious disease colleague with you and you try and bash it out together. What you have to remember is that if somebody hasn't got better with antibiotics, they may well have HLH complicating sepsis. So it's not infrequent that you have both. And then you just have to balance what you think is the risk of immune suppression against the benefit of immune suppression. And in the end, actually, I don't think I've ever regretted starting immune suppression. I've regretted being a bit wimpy and holding back.
Great, thanks. And another one, so in the context of EBV-driven HLH, do you see any association between higher levels of EBV viremia and the increased likelihood of developing HLH?
Yes, you do. And actually one of the key people in our MDT is Emily Sanchez, who's a virologist, who has really taught me that loads of, there's all, and I know you know this better than me, Claire, because it comes a lot from the pediatric and primary thing, HLH world, which is that often you get reactivation of EBV as the patient becomes sicker, as opposed to primary EBV infection being the driver of the secondary HLH. So it can be difficult to pull apart, but yes, very high titers certainly suggests that EBV is part of the problem, in which case we would add rituximab to the treatment regimen.
Okay, so and just going back to the one that you answered about differentiating sepsis and HLH and persistently spiking. So the follow-on question is, would you then treat with methylpred whilst continuing antibiotics for bacterial infection?
Yes, and actually there's some really nice data, I hope, coming out from something called the PROVIDE trial, which is really trying to answer exactly this question. We think that in about 5% of patients with proper sepsis develop what they call macrophage activation-like syndrome, which is effectively HLH. And if you look back at the original anakinra in sepsis trial, which was negative, if you look back at those patients and pull out the patients in that group who had a syndrome that resembles HLH with hindsight, those patients given anakinra, their mortality was halved. So what Provide is trying to do is to get that data prospectively and on purpose. So taking sepsis patients, giving them taking sepsis and hyperinflammation patients, giving them anakinra and looking at mortality, and we're due those results anytime soon.
Great. There's a couple more I think I'll just pick up on. So one, I think is a comment, EBV PCR frequently positive in the context of EBV-driven Hodgkin lymphoma, and T-neg NK lymphoma rather than reactivation.
Yeah, and it's so thorny. I mean, I remember the first ever HASC meeting we had. We spent about 2 hours discussing where EBV fits in all of this. And again, it comes back to, what are you trying to treat? And is it harmful to give some rituximab alongside all the other things that you're doing? So you have to treat the HLH because otherwise the patient will die, and then you have to treat the driver if you possibly can, because otherwise it'll just keep coming back and they'll die. So we quite often do lots of things in parallel. It's not neat medicine, I have to say.
Yeah. And any overlap between HLH and Castleman's?
Yes, I've seen overlap between HLH and Castleman's in HIV. Again, it's tricky, and it would be a reason to use tocilizumab, of course.
Okay. And I think we'll tie the last two. So Matt Collin, I entirely agree with him, and he entirely agrees with you that the role of bone marrow in HLH, BMA and HLH is, maybe not high.
Perhaps I haven't actually read the questions. I'm just listening to
you. But the follow-on is
the answer is, it's really difficult, because if you're in a place where like where you are and I am, we are full of people. The institution is populated by people who believe in HLH, believe in the need to treat these patients. But we still know that up and down the land, there are physicians desperately trying to treat patients with HLH, being told it's not HLH because the marrow shows no haemophagocytosis. So we absolutely have to, and one of HASC's big drivers is to get that message scrubbed out.
Yeah. So Laura's follow-up question was, any advice for consulting with haematology colleagues when you feel a bone marrow is required but haematology are not convinced? Well, it depends what you're putting on the form, I guess.
Get Matt Collin on them. Yeah, what you need, Laura, and anybody else, is to, and you're very welcome to email me. We have been in this situation before, and we have ended up getting HASC members to talk to local haematologists and say, I promise you, we've had X number of patients who have HLH with no phagocytosis on the marrow, and we need the marrow because we need to know it's not bloody. So I think this is about using the power of other people, and we have to be brave and say, we think this is HLH and this is what we have to do. So yeah, increasingly, because we can now all do MDTs on Teams and things, people are dialing in from across the land to established MDTs to get advice, and we will then phone out to the correct specialists and try and help.
Yeah, great. Okay, thank you so much, Jessica, especially answering lots and lots of questions as well. So
good.
Okay, thank you for your time. And now I'm going to hand over to Professor Joe West, who's a professor of epidemiology and a gastroenterologist at Nottingham, who is going to talk to us about the incidence and survival in an HLH population cohort. And he's sort of focused on using routinely available electronic health data to find out the outcomes for these patients. So thank you very much, Joe, for taking the time to talk to us today.
Great, and thanks very much for the invite. So I'm going to talk about the incidence and survival of HLH from an epidemiological perspective. So it doesn't really involve any conversations about cells and immunology, because first of all, I don't understand it that well. And also epidemiology is a fuzzy science where we're simply counting people and giving you the estimates of how common it is and how bad it is for people. And so what I'm going to do today is just give you a very brief overview of the epidemiology that's known about HLH in terms of its occurrence and survival, and then some preliminary results from the work that we're doing funded by Histio UK, for which we're very grateful. This is work that's part of a wider project looking at the occurrence and outcomes for both Langerhans cell histiocytosis and HLH, and it's a a big collaboration between a large number of people who are all listed below, and organisations. The key organisations, I guess, are Histio UK, who are funding it, Public Health England, who have a section called NCARDS, which is the National Congenital Anomaly and Rare Diseases Registration Service, and Mary Bithell is the head of the Rare Diseases section for that, under which HLH sits as a rare disease, which allows for research to be done on all patients in England without consent for assessing their medical data, which allows rare diseases to be researched in great detail. So first of all, I was just going to try and tell you how common it is, or indeed how rare. But actually the incidence of HLH in the general population has been very rarely studied. Mostly it's been done in the pediatric populations, looking at primary or familial HLH, and the best papers, really the only papers from that, come from Sweden, whereas a couple of papers from Inga Henter, who's of course very important in the HLH world in terms of guideline development, and they've showed consistently over 30 years that the incidence rate per million is 1.2. There's a large volume of publications from Japan, but really only one incidence study where they looked across the whole population, and they found that their incidence is 2.5 per million. It's unclear though from that particular paper whether this is all familial and primary, or whether it includes some secondary HLH as well. And really that's the best evidence that there is from across the world on how often this occurs. So how else can we measure the incidence of a disease? Well, in a disease like HLH, which is sadly so fatal for so many people, you can look at deaths from the disease as measured in National Cause of Death Registry. And these data I've taken from the Office for National Statistics publicly available cause of death registration system, and I've used the ICD-10 codes D76.1 and D76.2, which are HLH codes, and I'll come on to those a bit more in a little while, to say how many people died with an underlying cause of death with HLH over the period 2001 to 2016. And as you can see, it's pretty low in 2001, but it is a rising trend in deaths caused by this disease over the 15-year period. It's just under 1 per million by the time we get to 2016. So that tells us something about the occurrence, whether that's ascertainment, i.e. recording of the disease, as Jess has already referred to, or real increase in disease, it's difficult to say. So the other factor that Jess has nicely described are the underlying conditions that may lead to somebody getting particularly secondary HLH. And this figure is taken from a Lancet review of many case reports in the literature, of which there are several hundred, describing between 10 and 50 patients with HLH, and has combined them all to show you what the underlying diseases are. And they're broadly speaking infectious on the left-hand side of the screen, and predisposing other diseases, which are, as Jess referred to, malignancy or autoimmune. There are some medications that can probably trigger the situation, but they are often related to the underlying diseases of infection or malignancy or autoimmune disease. And so what do we know about the mortality of this condition? And you've seen some figures on this from Anu's work in primary HLH. And these figures that I'm about to show you are more about secondary HLH, which has an equally poor outcome. On the left of the screen, you can see overall survival in 73 patients from Washington, and the 1-year survival is around 50%. If you have malignancy associated HLH, then your survival is much worse, but still non-malignant associated HLH in this cohort was pretty bad. It's at 12 months, it was still only 60%. And here is the most recent publication from Germany. They have a registry that they're developing where they've also shown similar sorts of survival and variation by the underlying condition, from those who are autoimmune with maybe 70% survival at a year to those with malignancy, where in their cohort it's under 40% per year. So we don't really have any of this sort of information for the United Kingdom. We have no information about incidence. We have very little information about mortality and survival, particularly in secondary HLH. And so the objective of this project that we've been funded by Histio UK is to take an approach which is a sort of data-led epidemiological approach, which is the kind of work that I've been doing in gastrointestinal conditions for many, many years. And we've come to HLH and histiocytosis through a common interest of all the people involved in both diseases. And so what we've done is, in the data I'm about to show you, is we've taken data that are collected by general practitioners and submitted to something called the Clinical Practice Research Data Link. And that is run by the MHRA and the government. What they do is they take all the data and anonymize it, but before they do that, they can link it to other data sets of great value to us as researchers. So they can link it to cause of death data, hospital episode statistics, which tells us whether someone's been admitted to hospital and what for, and the cancer registry data, so you can see what underlying conditions or treatments people have had for cancer who are in primary care. And from these 4 data sources, we've pulled together a cohort of patients with HLH. Now, there's a bit of a mixture of primary and secondary HLH, but it's mostly secondary HLH, we think, although you'll see that that's still work to be done in the project. Within this data set, there are about 20 million person years of data, so it doesn't cover the whole country. It's just general practices that are submitting their data. Alongside this, using the NCARD system, we've been able to try and validate the use of ICD-10 coding to identify people with HLH. And through access via Nottingham, Sheffield, UCLH and Bristol, we've got 134 patients records in which we've compared the clinical records to the coding. And the bottom line is that nearly 99% of patients with confirmed, probable or suspected HLH on review of clinical records were coded with D761 or D762, which are the ICD codes for HLH. About 86% of patients without the disease had code D763, which is another code used for histiocytic diseases. And so in the following slides, you'll see that we've only used D761 or 2 to identify patients with HLH. And so what this shows you is that we can be pretty confident that someone coded with these ICD-10 codes has HLH, but we will be missing some. So the incidence rates I will show you are likely to be underestimates of the true burden of disease. And that's not counting people who haven't even been diagnosed because people haven't recognized it in the first place, as Jess was alluding to previously. So we have 208 patients with HLH from 2000 to 2016. And these are the characteristics and comorbidities of the patients. You can see that it's a broad spread across the age groups. There are a preponderance of males. Hematological cancer is one of the key underlying conditions in this group. About 16% of people had a hematological cancer, and I can tell you that does vary by age, with the people over 45 having the majority of those cancers. Within hematological cancer, 3/4 of them have lymphoma. And I've just produced a couple of other interesting facts here for myself and the rheumatological members of our team. So rare rheumatological disease is present in about 17% of the cohort, and that's 2/3 of that is made up of systemic juvenile idiopathic arthritis and lupus, SLE. And the rest includes a mixed bag of diseases, including, to answer Laura's question earlier, one PMR patient. So you can see that the hematological cancer and rare rheumatological disease, as has been identified previously, is present in this cohort. Of particular note to ourselves in gastroenterology is inflammatory bowel disease, and 4% of the patients had that, which is maybe 2 to 3 times more than you would expect in the general population. And that's partly why we came into this, because in our IBD MDT in Nottingham, we observed, we discussed a patient who had developed HLH, who was naive to EBV infection, and once treated with azathioprine developed overwhelming EBV and HLH secondary to that. You can see there at the bottom, I've quantified those who were on chemotherapy in the 2 months prior to their HLH diagnosis, and also azathioprine ever, just to try and give some context to the characteristics. You'll note that infection is missing, and that's because I haven't classified that yet, and that's more work for me to do. So here are the results. We show that the incidence of HLH per million person years in England between 2000 and 2016 rises from about 1 per million in 2000 to approximately 2 to 3 per million in the last 3 years, 2016, 15 and 14. And you'll note that those trends mirror the cause of death. So as more people are being diagnosed with it, we are seeing obviously more people being assigned a cause of death for HLH. What happens to them after they're diagnosed? Well, this is the 1-year survival following their HLH diagnosis overall and by age and gender in the 190 cases who were alive at the start of follow-up. And you can see that much like the Kaplan-Meier curves that I showed you earlier from other cohorts from around the world, the survival from HLH is about 50% at 1 year. These are truncated at 1 year, so it's when you get to the end of the x-axis that you need to look. Slightly better than elsewhere, but the confidence intervals are quite wide. Notably, men in the blue line here on the left-hand figure for gender, they do worse, substantially worse than women. And you can see over here the estimates by age. If you're older, these 3 lines constitute those over 45, you have the worst prognosis. If you're 0 to 15 or 20 or 15 to 20, 25 to 45, then you have the best prognosis. But intriguingly, between those between 15 and 25, they actually have an intermediately bad prognosis, doing really quite poorly following the diagnosis of HLH. So as with many other studies from around the world, we show that the survival following a diagnosis of this disease is really quite bad. So in conclusion, I hope I've persuaded you that we know that incidence studies of HLH are rare, but from those the estimated incidence is around 1 to 2 per million. And we had no previous estimates of this in the UK. Underlying diseases in people with HLH can be broadly grouped as infectious, malignant, autoimmune, or some combination of these, or in many, it's unknown. Survival, estimated from studies outside the UK, is poor. I hope I've convinced you that our work has shown for the first time the incidence and mortality within the United Kingdom of this condition, and that both the incidence of and death due to HLH in England have risen over the last 16 years from around 1 per million to 2 to 3 per million in terms of the incidence of the disease. And the overall survival following a diagnosis of HLH in England is around 50% at 1 year. This varies substantially by age at diagnosis and gender. So why has the incidence gone up? Well, I think ascertainment is a particular issue that we need to consider, in that people are recognizing more and diagnosing it more. That's inevitably true. But one of the hypotheses for an increasing incidence over the period that you've seen is the increasing use of immunomodulator therapy in many, many diseases, both autoimmune and malignant. And there's the concern that that increase in use of treatments, which of course very important, might be leading to some of the increase that we've seen in incidence of HLH in the adult population. Thank you very much.
Thank you very much, Professor West. If you have any questions, please type them, submit them now as we hand back to Dr. Booth to do Q&A and summary. Thank you.
Thank you. Thanks, Joe. That was really interesting. A lot of work, I guess. We're going to see whether there's an increased incidence and reduction in death rate following the 2018 thing like we saw in the UCLH. But I mean, is your feeling that is it increased awareness, or is it better coding, or because this does rely, like you said, on people coding accurately?
Yes, I don't know that better coding's yet happened because it's a very difficult business. But I think the ascertainment, the actual recognition of the disease has definitely increased, and a change from calling things macrophage activation syndrome to HLH in medical notes and medical terminology, medical discussions, probably means that coders are able to code it better. So there is an ascertainment issue. But nevertheless, we know that you can look at prescription data, for example, for azathioprine, which has skyrocketed over the exact same period. And then there's many other drugs that are in, you know, it didn't even get prescribed, didn't even exist in the year 2000, that are now prescribed routinely in our practice in gastroenterology, and is true in rheumatology and many other autoimmune specialties.
Yeah, so a positive comment from Nick Mann saying that he's hoping that HLH is now increasingly recognised because of COVID, having worked with medical registrars who hadn't even heard of HLH pre-COVID, so that is good. And then a question from Mark Bishton: is the incidence increasing for all ages? If azathioprine and primary EBV a factor, then would mainly be in young people, as everyone acquires EBV by 50?
Yeah, so in the data that I've got to show you, the increase in incidence is only in those over 15. It's actually going down in those under 15, which is difficult to explain, but could be something to do with the EBV actually prevalence going down over time. So the Americans have observed that the transmission of EBV and the prevalence of EBV is actually the age at which you first acquire it is going up. So it may be that you're more naive to it for longer as an adolescent and young adult. But again, that's a bit speculative from these data. I should say that our work with NCARDS that's following on from this will allow us to look into this in greater detail. And that's because we've got the whole of England covered in that study, where there will be 1,700 patients with HLH that we'll be able to present this kind of data for.
Oh, wow, that's great. So when do you expect to have some information from that?
Well, we've got the data and we're working on the analysis, so I'll crack on as soon as I'm off the call.
That's really exciting. Okay, well, it doesn't seem to be any more questions in the Q&A box. So thank you so much, Joe, for your time and a great talk. And I think I'll just take this opportunity to thank all of the speakers. We've had such a range of different talks today, all very informative and clear, and I'm hoping that the audience has found that useful. So I'm going to hand back to Lynn now for some final housekeeping issues, I think. Thank you very much, and thank you, Lynn, for organising all of this and the tech support as well. Thank you. I think it's gone very smoothly, and hopefully people have enjoyed it.
Thank you very much, Dr. Booth, and thank you to all of our speakers and our tech team. Ladies and gentlemen, just a reminder, at the end of the session, there will be a survey. It is anonymous, and we would welcome your feedback. For those of you attending the LCH session, we look forward to having you join us at 1:30, that's 13:30 precisely. Please log out now and log in again using the same link, and hopefully up on the screen you can see, well, Histio UK does have some resources to help you and your patients. Thank you all very much. See you at 1:30, or goodbye for now.